Hi everyone, and welcome to my midterm presentation on motor control and how this course has altered my clinical practice. As most of you know already, I'm a clinical education coordinator for an undergraduate athletic training program in Kansas. So this project was a little difficult for me as I no longer have a patient population that I evaluate, treat, rehabilitate, or monitor on a daily basis. However, when I really thought about this topic, it occurred to me that my patient population is now undergraduate students and their education. Just so that you're aware, my institution is also currently in the process of developing a curriculum to transition to an entry-level master's in athletic training, which could also be seen as my area for implementation of this information. In athletic training education, we have a consistent teaching method specifically for evaluation. We teach our students the methodical way of progressing through an evaluation. We use HOPS or HIPS, whichever you choose, history, observation or inspection, palpation, and special tests, as well as teaching them to check the joints both above and below to assess if there are injuries or compensations happening around the affected joint. However, this poses the question, what if the compensatory movements aren't occurring at the joint immediately proximal or distal, but rather in a more centered to the trunk or core area? Students often miss those because they aren't necessarily taught to look at the whole body movement. Rather, they inspect the specific motions of those affected joints. At a previous institution, there was an osteopathic school of medicine on our campus, and our program's medical director was a DO, which has given me insight into looking at injury or illness in a more holistic manner rather than treating my patient's symptoms. I think that DOs have a great approach to medicine and healing in that if we don't heal the underlying causes to pain, injury, or illness and only treat the symptoms, the condition will never completely resolve. One of the most personally impactful readings thus far this semester for me has been Hodges and Tucker's article on moving differently in pain, a new theory to explain the adaptation to pain. As an educator, there is a fine line between having the desire for your students to retain the information you are covering in class and wanting them to gain the big picture perspective. Pain is one of those concepts. There is no rhyme or reason to predict how someone will move to avoid painful motions or activities, so it is important for students to understand that pain can have major effects on the body. As Hodges and Tucker presented in their pain theory, there is a redistribution of activity, mechanical behavioral changes, protection from future pain or injury, the motor system changes on multiple levels, and there are short-term benefits to those altered movements. However, there are long-term consequences. At the undergraduate level, we don't require students to have an extensive knowledge of the brain or neuroplasticity, but we want them to recognize that a lower extremity injury has the potential to affect gait, which includes altering upper extremity movement patterns during propulsion. If alterations aren't addressed relatively quickly, as a clinician, they may spend more time correcting biomechanical issues rather than treating the affected area. In most injury assessment or therapeutic rehab courses, students are taught special tests or assessments to identify issues for specific body regions or injuries. One of the most common examples utilized in athletic training education, from what I've noticed personally, is a lateral ankle sprain. It is one of the most common injuries to affect athletic and physically active populations, and students are instructed on a variety of tests or assessments to narrow their rehab focus or other needs. One of those assessments is the balance error scoring system, looking at ankle proprioception in 3 stances. A in the picture is double leg, B is single leg, and C is tandem. and they perform these on a variety of surfaces. Research has investigated that postural defects can be identified in patients with ankle instability, specifically after an inversion ankle sprain during the BEST test. However, after speaking with a variety of students, the focus of instruction is not on another area other than the affected ankle comparatively to the uninvolved side. Finoff et al. Looked at the reliability of the BEST test, which concluded that there was moderate to high reliability with inter and intra-related reliability, specifically looking at postural changes during the assessment. If there's evidence to support the use of these assessments for additional screening tools, why are we as educators not incorporating this information into the classrooms? This brings me to the SFMA that we have spent extensive time learning and applying specifically during the on-site portion of this course. I had the opportunity to learn the functional movement screen during my master's degree program. However, this was my first experience with the SMFA. The reading from Glaus et al. Established for me that the Selective Functional Movement Assessment is a reliable assessment, specifically intra-rater reliability, and that those reliability levels increase the more time that is spent immersed in and practicing the skills. This assessment really seems to have a holistic approach to gross motor patterns that are often overlooked with a simple evaluation, which we do in the clinic or athletic environment. Breaking out each of the top tier movements and developing a problem list and then utilizing those corrective exercises seems completely well-rounded and extremely useful in the clinical setting. I feel like this is information that an upper level student, once they are proficient in their evaluation and rehabilitation skills, could immensely benefit from learning. Kim and Yim conducted a case study looking at the use of these corrective exercises from the SFMA in patellofemoral pain syndrome patient. They found that the assessment as well as the use of the corrective exercises were effective in treating the chronic condition as pain based on the visual analog scale decreased and overall function of the movements increased over time. Integrating evidence such as this into courses of athletic training education could be highly beneficial and produce more effective clinicians in the future. I hope this presentation shows how I've been contemplating how to integrate this wealth of information into my current setting, but also looking into the future and how it can be beneficial as our educational setting moves to an entry-level master's. Thanks.